Hi, welcome. We are continuing some work around S-197. And we have in Elena Barabee from Fremont Care Board, who's going to talk to us about a report that I don't know, is it commissioned? Was it, we ordered, we mandated, statutorily required some report. And you're going to talk us through it a little bit.
Thank you. Elena Barabee, Director of Policy at Fremont Care Board. Thanks for having me. So this report was part of Act 17 of 2019. It was a joint report between the Green Mountain Care Board and DVHA. And we did this work as part of a broader set of states that were getting together to define and measure primary care spend as a proportion of our total healthcare spending. And the report focused on a Vermont-specific definition of primary care, which I'll get to in a moment. But there was a stakeholder group that was created and convened. This Vermont definition of primary care was created, and then we calculated the measure based on 2018 claims and non-claims data using the all-payer claims database that we have at the Green Mountain Care Board. And that report found that between 5.9 and 10.2% of healthcare spending is on primary care. So that report, the 5.9% is if you just use claims, and the 10.2% includes non-claims data, such as Blueprint for health payments and other kind of population health payments that fall into that bucket of work. What's important, and I sent around a one-pager that summarizes some of these key statistics. So the report is quite dense, but tried to pull out kind of some of the main things for you. So, I think it's important to understand what's in that 10.2%, that big number. So in the Vermont definition, that was convening a stakeholder group, defined primary care in terms of providers, services, and settings. So you have family medicine, internal medicine, general practice, pediatrics, nurse practitioners, physician's assistants, naturopaths, OBGYNs, and osteopaths. So those are all of the providers that were included in the definition. And it was, across a range of services, which included office visits, preventative care, care management, mental health, substance use disorder services. So you can often get, similar primary care-esque services from a specialist. Like if you have a rheumatoid, other kinds of specialty care, you could go get kind of those kinds of things there. You could get it in a kind of acute hospital setting. But here, this is really focused on kind of primary care and related clinicians.
Can I interrupt?
Yes.
Okay. So we took family medicine, which is a specialty, internal medicine, which is a specialty, general practice. I don't know what general practice is.
So this is just kind of another set. So we're taking kind of some of those Medicare, those claims-based definitions. So when you have a claim, there's different ways to categorize who delivered that service. And so we've checked all the boxes that could possibly fit. Yes.
So when you get to things like nurse practitioners and physician assistants, they aren't technically a specialty.
Right.
So how did we extrapolate out the ones like,
Right.
You're a physician assistant working in the emergency department or in orthopedics?
Yep.
Not.
You're immediately testing my knowledge. But, so there are different ways to do it. And I just have to go back and look at how we did it. But some of the newer methods, because we don't classify those, all practitioners as primary care and non-primary care, you can kind of look at their claims and look at kind of what they're doing and allocate them that way. Or you can kind of see where they work and if they work with, primary care physicians. But you're right, there isn't a great way to identify those kinds of clinicians in terms of their specialty. I can look up exactly how we did that here. Okay.
I think that's the same question. I think the same question as I have around the mental health services. I'm assuming you didn't focus on like designated agency clinicians. This, I'm assuming, includes all of them and it's more diagnosis code based.
Yes, very broad definition.
So you looked at private provider claims as well?
No, so I think I have to go back and look at mental health. So this was part of, I think the non-claims portion was more challenging, and there were actually some non-claims data that we were not able to allocate many years ago. So, there are some claims that are non-claims that are excluded. So we know that there's some spending that's happening that's not reflected here. Yeah.
Is this thing from 2020?
2018. Because claims takes a long time. That was the latest available data we had at the time. Yeah. Can I keep going?
Yeah.
Okay.
Keep going.
Okay, so there's the definition. So what did this report, kind of what were the insights? I think the Vermont definition, the report that focused on the Vermont definition, found that overall 8.9% of all payer total cost of care was attributable to primary care. That's just the claims, and then the 10.2 includes the Blueprint, CHT payments, et cetera. Medicaid had the highest share of primary care spend, and that also included mental health spending and SUD, or substance use disorder spending. And then Medicare was on the lower side, 5.5 to 6.5% of Medicare total cost of care spending. Then, as I mentioned before, there's this NESCO primary care report. So this was a group of New England states. This is on, the link to this report is on your website as well. And this report compared Vermont's spending to other New England states using a broad and a narrow definition, which was a little bit more tailored than our Vermont definition, but kind of gives you a sense with and without some of like the OBGYN, for example. But their report has a breakdown of exactly what's in and out of those definitions. And that found that Vermont had the lowest commercial spend on primary care across New England states, so 4.9%. Versus Massachusetts, which had the highest at 8% using the narrow definition, but this was consistent when they used the broad definition. We had 7.4% primary care spend versus 11% spend in Massachusetts using the broad definition. And then Vermont had kind of average to higher spend if you look at government payers across New England states, so Medicaid and Medicare.
They look at the disparity between Medicare and Medicaid is a really big number. Did they look at that and like identify? I mean, why would Medicaid be 25%?
Right. And I think this is where you get to the how we look at dual eligible spending, for example. I'm not exactly sure how they factored that into here, but I think having the mental health and SUD treatment available to Medicaid may have something to do with that. I don't know. I have to go back and look and see how and if that would be included in the Medicare spending in the same way, or if there's overlap in these populations. That would be maybe one reason.
Would that account for the difference between Medicaid and commercial?
I don't think that would be the same. It could have something to do with it.
Okay. I'm just trying to figure out, are we comparing apples to apples or apples to oranges?
We are likely comparing apples to oranges a little bit. Yes.
All right. Thank you.
That's really all I had. I mean, I'm happy to answer more questions, but those are kind of the big, it's a lot of data analysis for a couple of statistics. So
Go ahead.
I mean, it just seems like such a small number for primary care, like.
I can't hear Wendy.
Oh, sorry, it seems like such a small number for primary care, which I guess you did the New England, like, is there like a national average, like?
that's a really good, I mean, I think part of what this NESCO report wanted to do was to build kind of a standard way of looking at it, to the apples to oranges question. There isn't like a national all payer claims database, so it makes that kind of analysis really difficult. But there are we can compare using all Medicare claims, like how states may differ in terms of their primary care spend to get like a general sense. So, we could look for some data on that. But I
And then I'm
think
wondering if it'll go down even more now that people are not covered or their deductibles are
likely,
increasing
yeah,
so high that they're not gonna see their primary.
right, yeah, absolutely. Yeah, and
Interesting.
Um, so we used VCure's data. So other than percentages, what are we talking in real dollars here? Keeping in mind this was 2018.
yeah,
So what is the projected total spend on healthcare in Vermont by all payers?
so this report at the time used this total cost of care measure, which is kind of a subset of the total healthcare spending. So if you compare it to our expenditure analysis, it's a little bit different, but that's a $2.63 billion figure. So if you take 10% of that or 6% of that, that's the primary care dollar you're talking about. And then we're talking about, there's different ways of measuring who actually got that care. There are a lot of people who didn't get care at all. Are we allocating those dollars to those residents who didn't, or are we talking about dollars spent on people who actually access care? So that it's really important to know, depending on what you're trying to figure out, how you're, allocating those dollars is really important.
Do we have any, and I'm just thinking about like the Green Mountain Care Board and their role around hospital budgets. Additionally, the role you play with rate review. When you do Blue Cross Blue Shield and MVP, do they break down for you how much is spent in primary care?
We do. We look at primary care. We can look at primary care, hospital care, drug spending. We look at those drivers, and you can kind of see the major drivers as being, traditionally hospital spending and spending growth and drug spending.
So we know that since 2018, that spending has increased. We can all agree. And we know that the drivers have been, we've seen, because I know we've seen the little charts that go along, and then so we know drug spending, hospital spending so it would seem to me that percentage to primary care would be going down, I'm assuming.
I would guess that it would go down, but I would need to bring that back to you. Yeah,
Okay.
as a relative sense, if our hospital spending has grown over time, then it has to come from somewhere, it's proportion, yeah.
And I think the other question I have is, if this information is coming out of VCures, there had to have been a sort of total claims looked at. What percentage of claims were actually identified as a claim, a primary care claim to the whole? I mean, was it just 10% of all claims were primary care? Or I'm trying to get a sense of how much we allocate financial wise versus how much care is being delivered. I think we heard earlier this year, I remember some testimony that we'd had that, it's less than 10% we spend on primary care, and yet they make up over 40% of all encounters or something. I'm looking over to Jessa because I can't remember who said it, but I feel like somebody did. And I'm wondering if we actually have data around that.
We should have data on that. I think we do have some reports we've been looking at recently related to our all-payer model reporting that we can probably look at and see if we can get some of those numbers too. Yeah.
Go ahead.
I'm just looking at the reports on page 19, the analysis of anticipated impact and increasing primary care spend and forward-facing recommendations is the phrase that caught my attention. Can you say a couple things about, next steps? Like, how does this report or the data that it finds weave in with the things that we're working on with payment reform for primary care? I know that it's sort of captured a point in time, but I've also just, in my glancing at the report, seen that it says, when you're gonna do future work, measure this all again.
Yes, that's a great question. And I'll give you my take on it related from our board perspective, but certainly speaking with the Agency of Human Services and Blueprint is important. But this report became, I think a lot of states have been looking at primary care spend and how do we increase primary care spend. And it was a major component of the first AHEAD model negotiation. And so we were actually in the process of updating this analysis and negotiating a definition with the federal government. That model has changed, and so there's still a primary care spend component. But I would look to AHS for the latest available information on that. So what should we do with it? I mean, I think that's a question, right? I think, some states do primary care spend targets in their rate review process. Some states are working on an AHEAD negotiation and have a primary care spend target as part of that model. So I think it depends on the state's approach to primary care reform.
In the budget process with Green Mountain Care Board hospital budget review, do hospitals who actually have primary care, do they break down that service line as far as costs and revenue?
We have kind of seen primary care revenues. We get a breakdown by department, but we have not made it an explicit kind of focus or, made any orders related to primary care, to my knowledge. Yeah.
My last question is, in 197, it appears as though we've tasked the Blueprint to advise Agency of Human Services around coming up with sort of targeted, like, methodologies in order to find sort of a per member per month amount.
Mhm.
Considering that the Green Mountain Care Board has done this work previously, does it make sense to then ask the Agency of Human Services to start over again?
I think that's a good question. I think we have a lot of infrastructure to build the spend measurement. I think if it's about designing a payment model for primary care, maybe they'd be better positioned to do that. Though there's overlap in some of that work. So I think that's a question. It's any question.
I guess I'm just thinking about the fact that we already have given the Green Mountain Care Board rate setting authority, and I'm not sure how this is different. Why we would task somebody else with setting a rate when you already have, when I say you, I mean the board.
Yes.
And the board already has rate setting authority.
We could do it with the authority we have.
Any other questions for Elena?
On rate setting authority, is it across the board, or is it more limited?
I think it's pretty open. I would like to have our general counsel weigh in on exactly how far that goes, but I think, we have explicit direction to establish hospital reference-based prices, right? But there was, and an allowance to set a floor for primary care or other types of services in 68 as part of that work. So yeah, so there's
Exciting.
Yep. Mhm.
Maybe one of these days we'll have Jen Carby go through and read the Green Mountain Care Board section. I don't know, what is it, a chapter or is it? It's a whole. I think sometimes we're really confused over the years of like what we've put in there and. Anyways, go ahead, Daisy.
Report says the board currently does have the authority to set provider rates. However, the authority has never been staffed or funded. In FY 2016, the board staff estimated the cost of implementing an FFS rate setting program could range up to 2.3 million, depending on complexity and structure.
Yeah. Yeah, I would agree. I would agree.
Yeah, but that's a
Fee for service rate setting.
Yeah,
So
I know.
I think what we're doing right now, right, like.
Deal, if we just got to that one capitated rate.
We can, yeah, the simpler it is, the better, yeah, the
It's
easier.
down to 1.3.
But I guess the point is that it's not just enough to give them the authority. We need to give them the money to do it.
Or the directive.
That too.
Yeah.
A little both.
And the resources. And the resources.
Yes.
Okay, any other questions?
So I have a question, but you're not gonna know this answer, but it came up this morning when we got anecdotal testimony about what pediatricians would want in order to have a per member per month kind of viable practice.
Mhm.
I don't have my notes written, but well, I do. $100 per member per month, which is way,
Mm.
I think if I understood it right, so maybe you can help me make sure I got it, that currently, well, the ACO is doing 63 and then another 5, so it was 68. So they were getting 68, but asking now maybe 100.
Yeah, and I think it depends too, like what's a per member per month versus what are the other ways these providers are getting paid, right? Like I think to the point made earlier, apples and oranges.
That
right?
was
Like,
because there's a
yeah,
fee
yeah.
for service.
Yeah.
And as Dr. Ramsey said, he'd rather have fee for service, which was a little hard to interpret.
Yeah.
And it doesn't have to be all or nothing.
Yeah,
You know, you can have, they're hybrid models where you have per member per month for some services and carve out certain fee for service for others.
does that make it more complex? I mean, that sounds,
I mean, just sometimes it's easier depending on what the service is. But that's where you have these stakeholder groups kind of weigh in on how would the payment best support the best care.
so if you were gonna, oh, sorry, if you're gonna take this, this is supposed to be effective on passage. But there's a lot of reports, seems like a lot of it is. So what's the timeframe could you imagine? The Green Mountain Care Board needing to do its work once it gets funded for whatever million.
Oh, so I think the reports in here are a little different than what we talked about, but I think
Okay.
some of, like, so I think there was one report in
Although
the
we had it.
197 version of this, I think if I recall, that required kind of focus groups and a lot of kind of touch points with communities and providers. And I think that we had a dedicated FTE for maybe a year to get that report done. So that's not, we could probably think of other ways of doing it, but that level of detail did require quite a significant effort.
So what is the level of detail required in order to do it?
Well, I think once we get into the bill and start pushing into it.
But just to summarize a little bit this morning, there's this increase in vaccine counseling.
Mhm.
And there's no way to get compensated for that, but they have to provide it. We spend a lot of time in education doing that. They were basically saying a lot of care does not get paid for in the fee for service model. And that pediatric specific needs need to be taken into account because you can't quote for services that will be provided. So there's a lot of those nuances to really provide the level of care that's going to make the difference
Exactly.
in the comprehensive primary care.
Right.
Would it be a blending of?
I imagine that they're exactly, I think
Yeah.
it's not going to be just a very simple formula. Yeah.
And maybe I'm editorializing here. I keep asking people like what would be, and we keep getting sort of numbers or ideas of how to just sort of sustain the system we have right now and just changing the methodology of how we do it to keep it at a sustainable level. I just keep asking, are we trying to sustain it or are we trying to elevate it?
Well, sustaining means that it doesn't crash. which is a worry.
Or are we trying to make it thrive?
We like to make it right, but we don't want it to crash either. Sure.
Okay, thanks, Elena.
Yeah, thanks for having me.
All right, we're actually done for the day, everyone.
Madam Chair, can I
Yes,
just
of course.
say, having served on that study?
Would you like to? Would you like to announce who you are?
I am like, it's a little bit, like, I haven't thought about it in years, it's a little bit of a post-traumatic stress response. It was a grueling.
Yes, okay, thank you.
Grueling experience. To plow through all of the imaginations to.
Yes.
It was a tremendous amount of work.
That's very smart.
So what do we take from that? Don't do it again?
Easy to update, don't sweat it.
Yes, we're gonna do it, yeah.
Yeah.
Think sometimes we need to do a grueling amount of work or something that we're gonna actually do something about. We wanna make sure it's directly applicable to something.
Did you see anything come out of this work?
From where I saw, I couldn't see anything. It was interesting to hear Elena just say that people have looked at it.
I looked at the recommendation section, there was nothing in the recommendations.
No, I think we didn't kind of. We haven't gotten any, yeah, we didn't have a directive, I think the head model was the place where that could have happened or may yet. Been, but, I don't think there's another vehicle, to my knowledge, that is actively using.
Yeah, just because you said something about it, I just wanna I think you have heard me say in this committee for months and months and months, maybe longer. I know zero days that it will ever happen. So.
How many decades have we been collecting data and how much more data do we need? You know. Yes, Jessa, how much more data do we really need?
Medical Society, I would, let the committee know that there have been advocates, for example, the Medical Society saying we don't just need to measure this anymore, we need to set a goal and make progress each year towards that goal. And we have reached various roadblocks to accomplishing that, but that has been suggested for various legislation along the year, so it was seen as a first step. The measurement was the baseline, there was an intent by some to then move that baseline, and that is where we are today. And when I testify further on 197, I would be happy to share more about how we could see that moving the needle, not just being a measurement that is sits on the shelf.
That's kind of where,
So could I ask a question?
how many more times do we need to measure it?
Yeah.
Oh, go ahead, Leslie.
So do you have a goal in mind? Is it a,
I will say other states have set goals that range from 12 to 15%.
you're talking about a number of goals?
A goal for what percent is the correct goal for where that, what percent of total cost of care should we be spending on primary care? There are a number of experts from other states and nationwide who'd be happy to talk about that work. Massachusetts has a bill with a similar goals. Rhode Island had a goal of 12, and I believe has met that goal, and it's increased it to 15. We have members who tell us it should be 20, but you could, but it should be based on what our goal is to strengthen our primary care system.
So I have another question. Have you come across anything that is a goal that actually influences population health outcomes in a meaningful way?
That is where that number, my understanding of where the 12 or 15% comes from is looking at other countries and health systems and what they spend on preventive and primary care relative to the United States. And that is sort of what and their outcomes based on more investment in primary care. And that's what's informed why it's not just a number, it's because we think there would be good outcomes
Right.
and improve the health of our population if we increase that investment.
So if I understand right, just so I clarify, that in other countries, let's say 15 to 20% spend on primary care is what they're doing and therefore having better outcomes, population.
Oh, I know you'll probably, but I think about, you know, when we start comparing to other countries also invest in childcare, education, childcare, food security, housing,
Rental,
which means sometimes you can spend a little bit less. So,
where do you put the resources?
yeah, where do you put the resources? Okay, well, everybody, thanks so much. We'll be back. We're not back until 9:30 tomorrow. So